We described the common mechanisms of bacterial resistance to antibiotics and explained the mechanism of action and spectrum of activity of glycopeptide, lipopeptide, and beta-lactam antibiotics. Now, given a patient with suspected bacteremia, let's recommend appropriate empiric therapy. Blood is considered a sterile site. There is no colonization of the blood. There is no defined microbiota for the blood or filtering organs. Specifically, the liver and the spleen have the role of filtering bacteria or organisms in general from the bloodstream. The liver specifically has a rapid response when it comes to filtration of the blood, whereas the spleen has a slow response in filtration of the blood. The definition of bloodstream infection is a positive blood culture plus signs and symptoms of systemic infection. Now, in general, it is possible for bacteria or other organisms to be in the bloodstream infection transiently, and then they get cleared out. So it's not necessarily an infection in the absence of systemic infections. Bacteremia specifically refers to the presence of bacteria in the blood, whereas fungemia refers to the presence of fungi in the blood. And candida by far are the most common fungi causing bacteremia. So the term candidemia refers to the presence of candida species in the blood. And lastly, viremia refers to the presence of viruses in the blood. And most bloodstream infections are monomicrobial, meaning they are caused by a single organism. And about 5 to 13% of all bloodstream infections are polymicrobial, referring to more than one species of organisms. Urogenital procedures may introduce E. coli as well. And we have infective endocarditis, which is an infection of the cardiac endothelium and can present as either acute or subacute disease. Most common causes of infective endocarditis leading to bacteremia is Staphylococcus aureus, Streptococci species, and Enterococci species, and rarely gram-negative organisms. Secondary bacteremia essentially means bacteremia as a result of another infection in the body. By far, the most common cause of secondary bacteremia is urinary tract infections. So E. coli and Enterococci, if they make their way into the blood from the urine, they can cause bacteremia. Next, we have respiratory tract infections that can lead to secondary bacteremia. Most common causes include Staphylococcus aureus, Enterobacterales, Pseudomonas, and Streptococcus pneumoniae. Next, we have intra-abdominal infections. Most commonly Enterococci, Enterobacterales, and Bacteroides fragilis, which is an anaerobic organism that can make their way into the blood. And rarely, severe skin and soft tissue infections can lead to bacteremia. most likely due to Staphylococcus aureus and Coag-negative staph. Now, when exactly should you suspect bacteremia? Patients present with general non-specific signs and symptoms that indicate a systemic illness or infection. Most commonly, fever, chills, sweats, fatigue, and anorexia may present. Now, this could be due to many things, but also they can occur in patients with bacteremia. So clinical suspicion of bacteremia essentially is high when you consider SIRS criteria. So there are 4 SIRS criteria. One is the presence of fever or hypothermia. Second is heart rate of more than 90 beats per minute. The third criterion is respiratory rate of more than 20 or PaCO2 of less than 32. And last one is white blood cell counts of greater than 12,000 or less than 4,000. Or if we have a bandemia in the patient, meaning more than 10% of the white blood cells are in SEGs. Now, if the patient has 2 of these 4, they're considered SIRS positive. And when you see that, the suspicion of bloodstream infection goes up. One thing to keep in mind is that it is common for patients to reveal a leukocytosis, meaning increased white blood cell, within 24 hours of initiation of glucocorticoid. So if somebody just started glucocorticoids and white blood cell went up, it's not reason to get a blood culture. Another thing to keep in mind is that people who have surgery, it is common for them to have fever in the next 48 hours after surgery, and that's not necessarily due to infection. It's just the inflammatory response to the surgical procedure. So keep that in mind. Now, if the patients are, if you are suspecting sepsis or hypotension or shock, typically people can consider bloodstream infection. Presence of indwelling catheter increases your suspicion of bacteremia. And other inflammatory markers such as C-reactive proteins, if they are elevated more than 10, ESR or procalcitonin, and there are other things that you can consider. In general, it is important to use your clinical judgment when you suspect bacteremia in patients before ordering a blood culture. Now, when it comes to fever, fever is not always due to infection. Of course, fever can be due to infection, but there are other sources of fever. For example, people with malignancies, cancer, can develop fever due to that. Autoimmune conditions can lead to fever. DVT, occasionally patients can develop fever as a result of that. There is a phenomenon called drug-induced fever. So there are certain classes of drugs that occasionally can lead to fever, specifically anticonvulsants, beta-lactams, minocycline, allopurinol, heparin, captopril, nifedipine, and ibuprofen have been associated with fever. Not in most patients, but a small portion of patients can develop fever. Now, drug fever mostly occurs after 7 to 10 days of drug administration, and it rapidly reverses once we discontinue those drugs. And upon rechallenge, the fever does occur within a few hours. And then, of course, there is a fever of unknown origin when we cannot really identify a source for the fever. So keep that in mind. So not everybody with fever necessarily has an infection. Now, blood culture is considered the gold standard for diagnosis of bloodstream infections. When counting number of positive blood cultures, it is important to know how blood cultures are obtained. A blood culture consists of a set of 2 bottles of blood. One bottle is for aerobic organisms and another one for anaerobic organisms. So the tests that are done in the microbiology lab, there are different set of tests done for aerobic and anaerobic. So there are 2 different bottles required to make sure that there are enough sample, specifically blood sample, to conduct those tests in the micro lab. Now, at least 2 sets, meaning 4 bottles of blood, is required, and each set needs to be from a separate site. And the reason for this is to really make it easier to interpret the results and rule out contamination. Because if you get all of the bottles from the same site, if the technique was not appropriate and led to contamination, but pretty much all 4 bottles will be contaminated. So it helps to get it from 2 different sites in order to minimize the risk of all samples being contaminated. So when describing positivity, the number of bottles positive will be described. For example, we say 1 out of 4 bottles positive for coag-negative staph, or we will say 2 out of 4 bottles positive for coag-negative staph. So that's essentially how these things are reported. Now, collection of blood cultures should not substantially delay the start of antimicrobial therapy, especially in febrile ICU patients. It is ideal to collect the blood before antimicrobial agents are started in order to minimize the risk of false negative, because just a single dose of antimicrobial agents will significantly drop the yield of blood cultures. However, again, this should not delay start of appropriate antimicrobials in patients. Let's discuss contamination of blood samples. So because blood cultures are commonly contaminated with skin flora, specific organisms may be contaminants. And the most likely contaminants are coag-negative staph, Bacillus species, Micrococcus, Crinibacterium, Cutibacterium. So these are the ones that are more likely to be a contaminant. So what it means is that if you have 1 out of 4 bottles growing coag-negative staph, you essentially conclude that it's a contaminant. But if you have 2 out of 4 growing coag-negative staph, because you have 2 of the bottle growing, that's unlikely to be a contaminant. So you conclude that it's a true infection due to coag-negative staph. Now, you only do that with these organisms. There are these other organisms that you never consider a contaminant. So Staphylococcus aureus, for example, because it's a deadly bacterium, if you only have 1 out of 4 bottles growing Staphylococcus aureus, you are obligated to treat it. You cannot count it as a contaminant, because if you happen to be wrong about the contaminant, Staphylococcus aureus can kill the patient pretty quickly. The same with the rest of these organisms here. So Streptococcus pneumoniae, group A streptococci, any of the gram-negative bacteria, Bacteroides, and even the fungus Candida species. If you have even 1 out of 4 bottles growing any of these, you should consider bacteremia and treat it. Now, viridans, strep, and enterococci, these are tricky. So they may be true pathogen or they may be contaminant. It's really, they are considered on a case-by-case basis, and typically infectious diseases physicians will be consulted for these to decide if it's a true infection or a contaminant. Now, let's talk about management of bacteremia. So blood cultures before antibiotics are essential, if possible. So if even 1 dose of antibiotic can actually eradicate organisms from the blood sample, so it can actually reduce the yield. So it will be more likely that nothing will grow out of the blood culture. So it's important to get the blood cultures before initiating antibiotics. But I say if possible, because, for example, if it's taking too long for the, if the staff are not available to get the blood cultures, which is extremely rare, you don't want to delay antibiotics. So it has to be within reason. In general, you want to give antibiotics within 1 hour. But, if it's taking like 2 or 3 hours for someone to come and get the blood cultures, it's okay to give the antibiotics before blood cultures, because we don't want that to be, at the cost of harming the patient. Now, source identification. It's important to know how the bacteria got into the blood, right? So bacteria don't belong to the blood. So you need to identify the source. And that's important because we're going to talk about source control. Because without source control, you can continue to give antibiotics. Once you stop antibiotics, if you haven't removed the source, the bacteria will continue to come back. So it's extremely important to identify the source. So catheter-related bloodstream infections, which essentially would lead that, to the fact that the catheter will have to be removed and replaced with a new one. You can so if there is a catheter in place, you suspect that is the source of the bacteremia, and the catheter tip, for example, can be cultured to see it grows something that matches the blood culture. Symptoms, you can use the symptoms to identify where in the body the bacteria are coming from. So for example, if there is pain, for example, if there is low back pain, you might consider that there might be kidney infection. So you can use the site of pain to identify where the infection is coming from. Or if there is inflammation in a certain location, perhaps maybe it's a joint, or anything that you can identify from the symptoms. Microbiological cultures of the site. So if there is a wound, for example, and you culture it and you grow something, and the same thing is growing in the blood, or if you have a respiratory culture and it's growing something that matches what's growing in the blood, that identifies the source of the bacteremia. And of course, sometimes you just cannot easily find the source, so you may need something like imaging to kind of show you, within the body if there are, processes that could be due to infection. And of course, you identify the source in order to have source control. So you remove the source if possible. For example, if there are extravascular devices such as central line or prosthetic joint, you essentially remove them if possible. And once the infection is treated, you can replace these. And sometimes they may require consultation of other specialties. For example, if someone has cardiac hardware, cardiology team may be needed in order to assess whether its removal is possible. And sometimes surgery is needed, so surgical debridement. So if surgically they need to go in there and remove dead tissue, any things like biofilm, which we'll talk about another day. But surgical debridement can also be helpful for source control. Once bacteremia is suspected, it is important to start early empiric antibiotics, ideally after getting the blood specimen for culture if possible. Empiric essentially means that we don't know what the actual organisms are, so we have to do our best guess to see which organisms we need to cover until the results of culture and susceptibility become available. Mortality significantly increases the longer antimicrobial therapy is delayed, especially if the patient develops hypotension. So the choice of empiric antibiotics depends on the source if known. For example, cover urinary organisms if a urinary source of bacteremia is suspected. Use broad-spectrum antibiotics if severe infection, for example, hemodynamically unstable, if someone has septic shock, as an example. Cover multi-drug resistant organisms if patient has history of multi-drug resistant organisms in the past year, or high local prevalence of multi-drug resistance. Use preliminary microbiological data. For example, when gram stain tells you that the organism is most likely to be a gram positive or a gram negative, you can use that information to use appropriate antibiotics. And of course, you can use rapid diagnostic test results when available. Then you can optimize therapy using PK/PD principles. Because we are talking about bloodstream infection, intravenous therapy should be started initially with empiric therapy. This is the best route to treat bacteremia, given the site of penetration is the blood, and IV therapy is 100% bioavailable. And then of course you can transition to oral therapy for select pathogen-directed therapy, which we will discuss shortly. When it comes to bacteremia, it is important to avoid a number of antibiotics because of PK/PD principles. These agents have either high volume of distribution, meaning that they will have high tissue penetration, leaving suboptimal concentrations in the blood, or essentially they only go to a specific site. For example, nitrofurantoin only concentrates in the urine, the same with colistin. Tetracyclines and tetracycline derivatives such as tigecycline, have a very large volume of distribution, so you're going to have a very small concentrations in the blood. Oral phosphomycin and oral vancomycin also have low bioavailability. In fact, oral vancomycin is not absorbed. Now, a portion of patients with bacteremia may develop sepsis. The definition of sepsis is a syndrome of acute organ dysfunction due to a dysregulated host response to infection. So in this case, it would be bacteremia or bloodstream infection. We will use definition from sepsis 3, which is the presence or suspicion of infection plus 2 or more on the SOFI score. Septic shock is a subset of sepsis, and this is essentially where despite adequate fluid resuscitation, patients continue to have hypotension requiring vasopressors to maintain a mean arterial pressure of at least 65 millimeters of mercury, plus a serum lactate of at least 2 millimole per liter. Now again, in the case of bloodstream infections, not everyone with bloodstream infection will have sepsis, but a portion of these patients will have sepsis, and not everyone with sepsis will have septic shock, but a portion of patients with sepsis will have septic shock, and a portion of those patients will unfortunately die despite adequate treatment. Now here are some recommendations from the Surviving Sepsis Campaign guidelines for the management of sepsis and septic shock. So essentially, if patients present with hypoperfusion, we initially use fluid resuscitation with 30 milliliters per kilogram of IV crystalloids. And when it comes to crystalloids, we prefer balanced crystalloids such as lactated ringers instead of normal saline. And if the patient requires large volume of crystalloids, it is recommended to use albumin in these patients. And essentially, these patients, we want to target resuscitation to maintain a MAP of over 65 millimeters of mercury. Now, if despite fluid resuscitation, the patient does not achieve MAP of 65, that is when we go to vasopressors. So norepinephrine is the preferred vasopressor and should be used as first line. Now, if despite use of norepinephrine, the patient still has not achieved a MAP of 65, instead of intensifying the dose of norepinephrine, it is recommended to add a second agent, and the second agent should be vasopressin. And if norepinephrine and vasopressin combination still doesn't result in a MAP of 65, then a third agent, epinephrine, is added. And then, hopefully the patient at that point has reached a MAP of 65. And then at some point, hopefully you need to wean away from these agents, and the patient should be able to maintain a MAP on their own. But if there's, vasopressors continue to be required, it is recommended to add IV corticosteroids, and most commonly hydrocortisone 50 milligram IV every 6 hours is used. There are other recommendations, such as, of course, these patients will need pharmacological VTE prophylaxis, and that's also true outside of the ICU. For hospitalized patients with sepsis, they need pharmacologic VTE prophylaxis. If the patients happen to have a glucose of over at least equal or greater than 180 milligram per deciliter, it is recommended to initiate insulin therapy. And for patients who can be fed enterally, it is important to start early enteral nutrition within 72 hours. Now, the timing of initiation of antimicrobial agents are important, especially when patients have sepsis or septic shock. So if septic shock is possible, or if there is a high likelihood of sepsis, it's recommended to administer antimicrobials within 1 hour of recognition. If sepsis is possible without septic shock, that window is 3 hours. So, it's recommended to administer antimicrobials within 3 hours of recognition. And if there is low likelihood of infection without shock, then it is recommended to actually defer antimicrobials while closely monitoring the patient. The next thing to consider is whether MRSA coverage is needed. If there is a high risk of MRSA, It is recommended to use empiric antimicrobials with MRSA coverage, whereas if there is low risk of MRSA, there is no need for that empiric antimicrobial therapy to include MRSA coverage. Now you might ask what would be considered high risk of MRSA. In general, prior history of MRSA infection or colonization in the past 12 months is considered, and recent IV antibiotics, typically in the last 90 days, is a risk factor for MRSA. And there are other things that the guidelines mention, such as history of recurrent skin infection or chronic wounds, presence of invasive devices, hemodialysis, recent hospital admission, or severity of illness. And then the last thing to consider is whether the patient needs double gram-negative coverage. And this is essentially for multi-drug resistant organisms such as Pseudomonas or drug-resistant Enterobacterales or other non-fermenting organisms such as Acinetobacter. So if there is a high risk of multi-drug resistant organism, it is recommended to use 2 antimicrobials with gram-negative coverage empirically. So, essentially this usually translates into having 2 agents with pseudomonal coverage. Whereas, once the results of the culture and susceptibility are available, then we can switch to just 1 antimicrobial based on the results. So this is the 2 antimicrobial is just for empiric period. And then for patients with low risk for multi-drug resistant, there is no need for double gram-negative coverage. Just a single agent is sufficient. Now, what's considered high risk for multi-drug resistant? It's proven infection or colonization with antibiotic-resistant organisms within the previous 12 months. And you can also use local prevalence on Antibiogram, for example, to see if there is a high risk, high antibiotic resistant rate. Other risk factors that the guidelines list include nosocomial infections as opposed to community-associated infections, broad spectrum antibiotic use within the last 90 days, concurrent use of selective digestive decontamination, travel to highly endemic country within the last 90 days, or hospitalization abroad within the past 90 days. As I mentioned previously, the blood culture is the gold standard for diagnosis and management of bloodstream infections. Now you will see that from the time the patient is admitted or is at the emergency department when they present, it typically takes about a day or 2 until the gram stains give us some clues about what the patient might have, and then it takes about 2 days from presentation to identify the organisms, and then another 2 days. So it will be another day. So it will be at day 3 at minimum that susceptibility results become available. So it takes some time to know if the patient is on appropriate antibiotics, and if the patient is not, that essentially means that there has been 3 days that the patient was on inappropriate antibiotics. In other words, if something was resistant to it. So that's where the rapid diagnostic tests come in, because within the first day of the patient presenting, so typically within the first 12 hours, there's a good chance that rapid diagnostic tests can catch what the patient has, if it is one of the common organisms causing the infection, and guide us in optimizing therapy with appropriate treatment. So most commonly, BioFire BCID2 is available for blood cultures, and it can catch the most common causes of bacteremia, so Staphylococcus aureus and some of the gram negatives, including Enterobacterales, and also tell us about resistance if it happens to be there, so that we can intensify treatment. There is also Verigin that's essentially doing the same thing. It may take a little longer, and there are other PCR rapid diagnostics that are available that are extremely helpful in managing bloodstream infections.